Hi friends, welcome to my channel. Today we will be seeing the part 2 of the care of the Venti series. In the in part 1 we have already discussed about the different care, about the different supplies that need to be present while intubating a patient, and also for the care of the patient, mechanically ventilated patients. And now we will look about the monitoring of the ventilated patients, how to monitor. Vitals is a basic parameter that needs to be monitored in this ventilated patients. First is the TPR, that is the temperature, pulse and respiration. So the standard temperature, pulse and respiratory rate of this patient should be monitored properly. So if the temperature of the patient is increasing or decreasing, so that may affect the patient. If the temperature is decreasing, as in case of in ICUs, the temperature is already low. If the temperature is less, so provide some heat support or cooling as indicated. So based upon the temperature of the patient, monitor the ECG changes in the monitor, okay, in the cardiac monitor, all the changes that are there, and also see the placements of the lead, whether it is correct or not. Then the heart rate and the rhythm also should be checked. Then the respiratory rate, the rhythm, the plethysmograph should be checked, and periodic auscultation of the patient's chest should be there, whether there is bilateral entry of on both the sides of air on both the sides or not. That should be checked. Then check the atrial blood gas. In ventilated patients, we mainly do the ABG. So in order to see how much is the CO2 retention. Sorry. The PCO2 levels, the PF ratios should be checked. Then SpO2. In SpO2, we mainly use the pulse oximeter for measuring. So there can be different types of probes, can be there, flat probe or clip probe. So check the placement of the pulse oximeter. If you are not getting the SpO2 in the monitor, then reposition or relocate the sensor in other hand or in the peripheries, wherever in the legs, if you are getting, so should be used. And because in some of when the patient is in a inotropic support, so the peripheral capillaries which are there, they get constricted, so and the hand peripheries get cold, so it may be difficult to get the SpO2 of the patients. In that case, cover the patient properly if the patient is on NORAD support or vasopressin. So cover the patient properly and put a warmer and place the SpO2 probe so that you can get the reading in the monitor. And also check the atrial blood gases and compare the PaO2 with the SpO2 of the patient. Coming to the blood pressure, so the blood pressure can either be directly monitored, that is invasive or non-invasive blood pressure monitoring, and main that is the systolic and diastolic, and map should also be seen. Blood pressure can be measured by either through the cuff method, okay, or if the patient is on some NORAD support where BP monitoring, it should be accurate. So in that case, invasive means direct ABG should also be used. Invasive monitoring should be used. So in the invasive monitoring, you need to see for under dampening or over dampening. Okay, so sometimes the ABG line may not be patent enough, and you should also check the level of the that transducer. Okay, it should not be above or below the heart level, it should be at the heart level, that is the phlebostatic axis. Then also whether the transducer is properly connected or not, the that pressure bag, whether the pressure is proper or not, around 250 to within 250 to 300 the pressure should be there. And flushing of the line and backflow of the means atrial line should be checked for the patency. In case of invasive monitoring, all these things should be taken care of. And in non-invasive monitoring, with the help of the cuff size, whether the cuff is properly fitted, whether the pulses are palpated, can be palpated or not, and also if and also change the locations during the readings, because in one hand if you continuously go on taking the reading, so it may be it can cause edema, or it can be discomfort for the patient, and also the skin in which the cuff is placed. So change the uh, locations while taking the readings. Coming to the EtCO2, that is the end tidal CO2 levels. So as I've told you in previous lecture that in HME filter there is a port in which this EtCO2 monitor can be connected, or there are other means non electrical appliances are also there, but there are means electrical appliances will give an accurate reading. So this end tidal CO2 is mainly used to check for any tube occlusion. If the tube is occluded or if the tube is disconnected, so EtCO2 will indicate, means there will be less EtCO2 reading in the monitor. And also check for excessive dead space, and check the atrial blood gas levels of the patient should be checked while the patient is on EtCO2. Then next is fluid balance. So in mechanical ventilated patients, so they might be have some kind of dehydration can be there. So intravascular volume status for monitoring their hydration should be checked with the help of the point of care ultrasound. Their body weights, physical examination, okay, and person dehydration assessments should be done by the pinching method, okay. Then monitoring the total fluid volume administered and comparing it to the total fluid volume that is produced. So intake output charting is very important in this mechanically ventilated patient. So if it is a cardiac or renal patient, so their fluid intake should be monitored properly, and output should also be seen. So in the intake mainly we add up all the inotropic supports, then all the drug dilutions, feedings, any fluid bolus that is being given. Okay, everything is added up together, and in the intake we calculate it for 24 hours. And in the output also same thing, if the patient has any kind of drains, or in RT aspiration if something comes and we discard it, so that thing. Then any vomiting episodes of vomiting in the mechanically ventilated patients, mainly vomiting might not be there because they are sedated. So the urine output, so that is very important, urine output and soakage. So in sepsis patients the skin might get have blisters and there might be soakage, so those things need to be calculated while monitoring the output. So intake output should be monitored, and we should check the balance, whether the intake is more than output or the output is more than intake. So mainly in ICU patients, we don't want the patients to get dehydrated. So always we target for a in more means the intake should be more than the output. And in some of the cases, like in cardiac issues, there might be means negative, means like 500 negative should be kept. The fluid balance should be 500 negative, like that. Or in renal patients, the intake might be restricted to some, or in some cases there might be order of keeping the patients in neutral fluid balance. So all these things based upon the condition of the patient, it is means taken into consideration. But we want the patient to remain hydrated, so we keep intake more than the output. Then coming to the respiratory rate, so respiratory rate and the respiratory effort of the patients while the patient is on a ventilator, if he is spontaneously breathing, is very important. Okay, when he is on spontaneous breathing, otherwise in other controlled mode ventilation, respiratory rate we are fixed, so we need not worry because ventilator will provide the, means will look after the rate. But in a spontaneous breathing, respiratory rate and effort should be checked. And in spontaneous breaths, mainly we need to check the tidal volume and the peak pressures, and all these things should be checked. And if the patient has decreased respiratory rate, or tidal volume is less, or the patient has any wheezes, crackles, decreased lung sound, so the mode should be changed, okay, immediately. Saturation of oxygen should be one of the important thing that you need to see. So it is a non-invasive tool, and it helps in monitoring the oxygenation level in the mechanically ventilated patients. So the gold standard for oxygenation monitoring is the partial pressure measured on atrial blood gas. So you should look the PaO2 in the ABG as well as the saturation level in the monitor. Okay, and you need to compare it at what means based upon the oxygen level in the ABG. You need to change the FiO2, and also you need to take into consideration the saturation level of the patient. So on the ventilator, we typically target a saturation of 95 to 100 should be the goal, while in a patient is on a mechanical ventilation, okay, to mitigate the risk of both hypoxia and hyperoxia. Okay, so mainly between 85 to 100, if PaO2 is between 85 to 100 in the ABG and the patient is maintaining SpO2 around within 95 to 100, then we can decrease the FiO2 level, and based upon the which FiO2 level the patient is able to have a stabilized SpO2 and a proper PaO2 should be seen. Always we should target that the FiO2 means we should try to decrease the FiO2 level support through in the mechanical ventilator for the patient. Then EtCO2. When a atrial blood gas is performed, the PaCO2 should be compared with the EtCO2. Okay. So what means whether the patient is able to ventilate properly or not. So that would be checked by the EtCO2, means the expiratory volume, means the amount of volume of air that is being expired out. So it would contain the CO2. So whether it is it is means properly the patient is able to ventilate or not, that can be seen. So you should check the PaCO2 and EtCO2 and compare it. If the patient is not able to eliminate the CO2 through the expired air, so the PaCO2 would be rising in that case. So you should check the PaCO2, EtCO2 and PaCO2 both, and based upon the PaCO2, you should uh, change the respiratory rate of the patient if it is in a controlled mode, and the inspiratory expiratory ratio and the tidal volume. Okay, in some cases, like for example, if a patient is on is a GBS patient, okay, so in that case there would be means respiratory failure will be there, means the chest wall, the diaphragm is not able to contract or relax properly, so inspiratory effort might not be there. So in that case we should means PaCO2 retention would be more. So in that case the inspiratory expiratory ratio which is there, so it should be changed based upon the condition of the patient, or if a patient is on ARDS. Okay, so here we want the patient to inspire more, okay, because the oxygen levels are down in these patients. So in that case we use means the inspiratory and expiratory ratio mainly normally it is 1:2 or 1:3. So if in ARDS patient we want more oxygen should be delivered to the patient, so we would keep the inspiratory part more than the expiratory. Or in cases of patients with emphysema, so in that case this is an expiratory problem. It means the patient is not able to expire properly, expiration is not proper, and there is more air trapped in the lungs, so we need to keep the expiration more than the inspiration, means the normal expiration 1:2 is there, so we need to keep more the expiratory part, the ratio of the expiratory part more than the inspiratory. So all these things based upon the PaCO2 level and the EtCO2 levels, it should be changed. Then these are the EtCO2 monitors. Okay, so this is a chromatographic method by which EtCO2 can be measured. Then ABG. So ABG is the most important part when the patient is on mechanical ventilator. So assessing the oxygenation includes assessing the PaO2, is to FiO2 ratio. Okay, so whenever you are taking the ABG sample and doing all the atrial blood gas analysis, always calculate the PF ratio. Okay, normally it is should be more than 400. So based upon that PF ratio, you would be able to change the FiO2 ratio, or the how much FiO2 you need to give, that you can measure, and means that you can change in the ventilator. So when monitoring the PaO2 on mechanically ventilated patients, you should always aim for PaO2 of 80 mfHg, because we don't want the patient to be hypoxic or hyper, means more oxygen if it is given to the patient can cause oxygen toxicity, so it can cause damage to the lungs. So therefore more oxygen is also not good for the patient. Okay, so we should target around PaO2 of 80, so it may decrease the risk of oxygen toxicity. And if the PaO2 is above 150, so the FiO2 should be decreased as per the clinician's discretion. So it should be, means um, 80 to within 80 to 150, it can is means better. It should not go above 150. Okay, then coming to the alarms of the ventilator. So while working in with the ventilated patients, you might have heard of so many alarms. Okay, so many alarms are there in this with when the patients are in this ventilators. Sometimes high minute volume, high tidal volume, low tidal volume, high pressure alarm, low pressure alarm. So whenever these alarms are there in the ventilator, always check the patient first. Okay, always check the patient first, then come to the machine. Okay, so this is very important. Don't go directly to the machine. Check the patient first. It can be that the patient might have got disconnected from the ventilator, or the patient might be restless, or have got self-extubated. So it is very important that the patient should be checked. Whenever there is alarm, see the patient first, that whether the patient is fine, whether all the tubings are okay or not. Okay, whether the patient is having any cough, bronchospasm. So all these things should be checked, and then go to the ventilator. If everything is fine, then go to the ventilator and check whether there is any fault in the machine or anything else. So there are different types of alarms which are there. So like high pressure alarm. High pressure alarm mainly occurs when there are secretions in the ET tube. Okay, when in the ET tube there are mostly secretions are there, or any kinking, or the patient is biting the tube, coughing, gagging, or trying to talk. So or increased airway pressure from bronchospasm or pneumothorax. Okay, so in bronchospasm, coughing, so there can be high pressure alarm. Low pressure alarm mainly occurs when the ventilator tubing get disconnected, or the ETT, which is there, or tracheostomy tube get displaced. In that case, there is a low pressure alarm. Then high respiratory rate. When the patient is anxious or in pain, or the patient is restless because of the ET tube in the mouth. So in that case, there can be high respiratory rate, or secretions are there in the ETT or airway. So there can be high minute volume or high respiratory rate. So like means alarm like high respiratory rate is not there, but a high minute volume can be seen in the ventilator. Minute volume. What is minute volume? Minute volume is equals to tidal volume into respiratory rate. Okay, MV is equals to tidal volume into respiratory rate. Okay, so tidal volume into respiratory rate is the um, formula for mechanical minute volume. So, and in low exhaled volume, so here there will be low minute volume. Okay, low exhaled volume, so the exhaled tidal volume is less, ventilator tubing got disconnected, or there is a leak in the cuff. Okay, or which is causing ineffective full delivery of the oxygen to the patient. So in that case, there would be low exhaled volume or low minute volume, and here you will get high minute volume. Okay, so all these things need to be checked when the patient is on a ventilator. and peak inspiratory pressure, which is that is the PEEP. Okay, this is the pressure which helps to provide provide each breath to the patient. So when the patient is on a volume controlled ventilation, so the pressure might vary. So in that case, the sometimes the inspiratory pressure might be high. Okay, so the target PEEP is below 30. Okay, the target PEEP is below 30, and if the high PEEP is there, it indicates that the patient needs suctioning, or the patient has any bronchospasm or lung problem like pulmonary edema or pneumothorax is there. Okay, so there are two things, that is PEEP is equal to two pressures, that is airway pressure. One is airway pressure plus plateau pressure. Airway pressure plus plateau pressure, PEEP, peak inspiratory pressure. So in peak inspiratory pressure, what happens? It is a addition of airway pressure and plateau pressure. So airway pressure means the pressure in the airways, that is in the ventilator tubing, in the trachea, in the bronchi. So that is the airway pressure. Plateau pressure is the pressure in the alveoli. Okay, so these things can be checked. Okay, so if the some problem is there in the airway, so the PEEP will be high, or if some problem is there in the lungs or in the alveoli, like in ARDS, the lungs get filled with means there is hyalination of the alveolar walls. So in that case, or in there is opacification of the lungs, so in that case the PEEP will be higher, means the lung compliance decreases, the lung is not able to expand properly. Or in a patient with chronic bronchitis or COPD patients, the airway pressure will be high because the airway is getting blocked, so the PEEP will become high. So these things need to be checked, whether the problem is in the airway or in the alveoli or in the lungs. Like in pulmonary edema, there will be high plateau pressure would be there. So these things has to be addressed when if the alarm is there in the ventilator. So coming to responding to alarm, how to respond to the alarm. So first, as I've told you, check the client, then check the circuit, then the ventilator settings and the alarm limits, replace the filter. Sometimes the filter can get more moisturized and it can get wet, and so the resistance might increase. Or if there is more amount of vapor, means while inspiration expiration there is vapor inside the tubings, so it can the water get condensed and get collected in the tubing. So in that case there can be water collection and it can cause more resistance in the tubes. So remove water from the tubing and check the humidifier settings. Okay, check the cuff pressure with the help of the cuff manometer, and consider any more other ventilatory mode support for the patient, so that thing need to be seen. So ventilator asynchrony, sometimes what happens due to incorrect mechanical ventilator setting, so there is a fight between the patient and the ventilator. Means the ventilator wants to give breath, but the patient is not um, he is not able to take the breath. So that is known as bucking the ventilator. Okay, so or the patient might be less sedated. So in those cases, patient ventilator asynchrony might happen, and this can increase the work of breathing or can negatively impact the patient. So always check the ventilator setting, whether the patient is comfortable in that setting, and if the patient is restless, sedate the patient. Hypercapnia, hypoxemia, hyperthermia may develop if the patient's respiratory rate or effort aren't addressed, okay, in a timely manner. So all these things might happen when a patient gets more means if there is a asynchrony occurs. Then in case of ventilated patients, so you also need to assess the pain and the sedation needs, because these patients can't verbally express their needs, so you need to check their pain level and whether they need sedation or not. Okay, there are certain scales which are there, like the RAS scoring, the Ramsay sedation scales, and another one is the behavioral pain scale. Okay, is there. So research shows that self-extubation can occur despite physical restraints. Okay, so therefore it is best that when a patient is agitated or anxiety is there, so it should be treated with medication and non-pharmacologic methods such as communication, touch, presence of family members. If the patient's GCS is good, then this non-pharmacologic method should be used. Otherwise, with medications, it should be done. Patients receiving mechanical ventilator often received a significant level of sedation and analgesia. So this medications can also hamper with their body's natural reflex, and it can cause high risk for aspiration, keratopathy, means the corneal ulcers can also be there, and pressure sores. So therefore this all needs to be checked. Okay, so for preventing VAP and for preventing aspiration, always keep the patient's head and elevated for till 30 degree. Keratopathy and all this corneal ulcers, for this the patient's eyes should be kept shut, and also use some eye drops for that. And for removing, means for preventing pressure sores, always change the position of the patient every 2 hourly. Okay, every 2 hourly the patient's position should be changed to prevent the pressure sores. So coming to the pain and sedation management, the different scales that are used. So first is the behavioral pain scale. So it can be used in both intubated and non-intubated patients. So here you can see that there is scoring from 1 to 4, and there are three parameters that are being assessed. One is facial expression, movement of upper limbs, and compliance with the ventilation. So this is for the intubated patients. In non-intubated patients, there is facial expressions, movement of the upper limbs, and vocalization. So adding the three parameters in either in intubated or non-intubated patients, you will get the total BPS value. So 3 is the minimum and 12 is the maximum for BPS scale. Then coming to the another scoring system, that is RAS, Richmond Agitation Sedation Scale. So here you see 1 to 4 is towards the agitated side, means towards more violent, restless thing. So 4 is the most violent, 3 is very agitated, less than that 2 is agitated, and 1 is restless, and 0 means in a normal person, that is alert and calm. Then below 0 is -1 to -5. So here in -1 the patient is drowsy. So there is sustained awakening to voice more than equals to 10 seconds, the patient is awakened. In -2 light sedation, the patient briefly awakens and makes an eye contact with you for less than 10 seconds. Moderate sedation, that is -3, here some movement or eye opening would be there to voice, but there is no eye contact. So then next, so in drowsy, means here there will be awakening to voice and the patient is awakened for more than 10 seconds. In light sedation, the patient is awakened, but he makes a brief eye contact with you, less than 10 seconds. Moderate sedation means there is no response to voice, but there is response to voice, but no eye contact is there. Deep sedation, there is no response to voice, but movement is there on physical stimulation. Either you give sternal pressure, or you can pinch over the in the eyebrows, okay, or you can pinch in the shoulders. So these are the means physical stimulation methods that you can use for awakening the patient. Then -5, here the patient can't be aroused. Okay, here the patient cannot be aroused and there is no response to any kind of voice or physical stimulation. The patient is totally sedated. Next, coming to another scale, that is Ramsay scale, which is patient. First is patient is anxious and agitated or restless or both. Second is patient is cooperative, oriented and tranquil. 3, patient responds to commands only. 4, brisk response to light glabellar tap. So here if your light glabellar tap is there or auditory stimulus, so patients gives a brief response. Then B5, sluggish response to light glabellar tap or auditory stimulus. And 6 means no response to the stimulus mentioned in items 4 and 5. So this is the Ramsay scale. So we have seen three scales, that is behavioral pain scale, RAS scale and Ramsay scale. So with this slide, I come to the end of this video, that is part 2. So we will see other things about the care of the patient mechanically who are mechanically ventilated in the next part. So thank you and have a good day.